Hi, everybody. Welcome to this month's live Q&A. I'm Angela. I work at Winona, and I am here with our CMO, Dr. Mike Green. I'm going to let him do his own introduction and tell you a little more about himself, and then we'll get started. Take it away.
So hi, my name is Mike Green. I'm an OB/GYN. I also happen to be the Chief Medical Officer of Winona, which has kind of become my favorite thing to do. But I do continue to do full-scale OB/GYN. I deliver babies and do surgery and see patients, but mostly I take care of y'all on Winona. The real purpose of this is not for you guys to stand around or sit in front of your computers and watch me say stuff, except to answer your questions. So please put your questions in the chat. That's really what this is all about. So I'm gonna kind of talk for a while until we get enough questions, but it's gonna get real boring for you if you don't put your questions in. So type your questions in. Because this is mostly new people that are new to Winona, new patients. I kind of wanna start just talking about the process, what you guys can expect when you become a Winona patient, and also just a little bit about how it's designed and why it's designed that way, because for people that haven't done this type of telehealth, it can take a little getting used to, and it's a little surprising for some people. Like, how do you do it that way? How do you do this safely? So the big picture basically is that a patient comes on and they onboard to Winona, and basically that involves what's called an online adaptive interview. And so basically it's like what we would do in the office is ask you questions and then ask different probing questions depending on how you answer to get the information we need to be able to safely take care of you. So one of the challenges I had when we built this was to try and pare things down and ask absolutely everything I need, but ask nothing I don't need. So I don't know about you, but I've had the experience when you go to a new doctor's office and they give you this like encyclopedia that you've got to fill out with all this information that's just craziness. Honestly, I don't need to know that you sprained your ankle in third grade to, safely provide you hormone replacement therapy. So again, we really designed this to just ask the pertinent questions. And it's really mostly asked the questions that would make it so that it wouldn't be safe to give you these medicines. And if that's the case, then we politely let you know, I'm sorry, this isn't something that we can do for you. And so if you sort of survive to the end, that means that you're a good patient, a reasonable person to use these medications. And so then I built this algorithm that comes up with a dosing plan, with a prescription plan that we'll show you. And you can decide, yeah, that looks good, or gee, I don't think I really want this. Or you can say, gee, I have more questions. And then that moves forward, and the doctor, whether it's me or one of our other doctors, gets all that information. We look it over, see if there's any questions that we have for you, or answer any questions that you may have for us. And then if everything looks great, we go ahead and prescribe what's already been shown to you. And so that will be prescribed, and then we send you information on how to use it. And those prescriptions then get prepared by our pharmacy and mailed to you. So the nice thing is, except to walk to the mailbox, you never have to leave your house. So it's super duper convenient. Occasionally we'll have questions for you. And so before we prescribe, we'll say, hey, can you tell me more about this? Or do you have a question about that? Or you may have questions for us. And there'll be some back and forth. And this is in a what's called an asynchronous way. So basically you have a question, you ask, it goes into our inbox, we look at it, we answer it, goes into your inbox. And it's real nice that way because none of us have to make appointments. So you don't have to say, gee, I'm available at this time. It's like, oh, I'm not available, and have to find a time to dance. You wake up at 3 a.m. with a question, type it in. I wake up in the morning and over my coffee, I answer that question. And so it's a really convenient way of doing things. And when built right, which I think we've done, it's a very safe way to do it as well. So it's both safe and convenient, and allows us to provide you the medications you need in a safe way that doesn't sort of eat up your whole day going to a doctor's appointment, going to the pharmacy, and what have you. So that's kind of the big picture and how it works. So hopefully we got a few questions. And if there's more questions about the process, please put those through.
Yeah, we do. We have many questions. Wow. Lots of things. Okay, this is great. First question we have for today is a question from Catherine, who wants to know if all prescribers at Winona are OB/GYNs.
No, they're not. All prescribers are board certified physicians. We have OB/GYNs, and we have family docs, and we have some internists. Everybody that works for Winona is a board certified physician and has really a special interest in hormone management. But it's completely appropriate for a family doc or an internist that has the appropriate training to provide hormone replacement therapy. And I can tell you, I'm actually a board certified OBGYN, but I did a family practice residency before I did my OBGYN residency. I got through my family practice residency, and this sounds terrible, but I realized that I hated taking care of really sick patients. I just found it depressing. And so I loved delivering babies, and I was told I was good at surgery. So I did a whole second residency in OBGYN, and that's pretty much what I've done for my career. But because of that, I have a pretty good perspective of what it means to be a family doc and what kind of training they get. Family doctors are absolutely trained and appropriate physicians to do hormone replacement therapy. So we do have family docs and internists as well. They also get training in this. Again, we have a lot of OBGYNs, mostly because that's sort of where my social circle was at first. As we grew bigger, I started hiring outside of my social circle. But everybody that works at Winona, all the docs are board certified docs, and they're all with a special interest in hormone replacement therapy.
Okay, our next question I put in the chat. I don't know if Dr. Green wants to add to this, but it was the popular question of, is blood work needed to start at Winona? To which I answered, no.
So that's but I guess I owe you $20, for asking the question I wanted you to ask. So this is a really important question, and there's a lot of misunderstanding about this. The standard of care for hormone replacement therapy is that lab tests are not valuable in providing hormone replacement therapy, in either initially providing it or in follow-up adjusting the dose. And that goes against a lot of what your experiences may be. And there's some reasons for that. First of all, we're used to drawing labs for stuff. And so a lot of doctors who aren't real familiar with hormone replacement therapy just think they're supposed to draw labs, so they draw labs. But it's really not needed. The other side of this is there's a lot of money to be made in doing labs. And so a lot of these sort of menopause spas and that kind of thing, or even some of these online companies, they make a lot of money doing labs. And so they order all kinds of lab tests. And there's all kinds of different things people do. There's blood tests, there's urine tests, there's the so-called Dutch tests, there's hair tests, there's saliva tests. There's all kinds of unique ways people try and do testing for hormone replacement therapy. And the truth is, none of them really work. So the hormones vary crazy throughout the day, throughout the week, time of day, depending on what you've eaten. There's all kinds of variables in here. So the hormone level that you get at any one time doesn't really mean anything about where your hormone levels really are. And this can be really frustrating for patients. So there's a lot of people, I get a lot of patients that they went to their doctor and their doctor ordered blood tests because they had all these symptoms of menopause. And they said, oh, your blood tests are normal. You don't need anything. And they shoo them off and send them away. And yet now the patient's still suffering with all these symptoms of the menopause transition, and they're kind of ignored because their blood tests are normal. The problem is those blood tests aren't accurate. And then they come to me, to Winona, and we, you have all these symptoms of the menopause transition, you're going to do well with HRT, and we provide you medication and you feel better and it works. And so really there's no reason to draw blood tests. And I certainly, look, if you've done blood tests and you want me to look at them, I'll look at them. But honestly, I think it's inappropriate to make clinical decisions based on those blood tests because they just aren't valuable when you make bad decisions that way. So hormone replacement therapy is best started and adjusted based on your symptoms. Your body knows better than Unilab request. And so we trust your body, we listen to your body, and that really tells us everything we need to know.
Okay. April, I'm not sure if I'm saying your name right, wants to know if there's a treatment for excessive sweating.
There are treatments for excessive sweating if that's basically what the problem is. So some people have excessive sweating just as its own diagnosis that has nothing to do with your hormones, and there are treatments for that. We don't provide those. We really do one thing, and that's hormone replacement therapy. I remember somebody in residency told me, do what you do it really well, don't mess around with stuff you don't do because you end up doing a poor job of it. And so we do one thing, and I think we do it really well, and that's hormone replacement therapy. So we don't have the ability to prescribe medications simply for excessive sweating. On the other hand, some women, as they go through the menopause transition, get hot flashes and night sweats that cause excessive sweating because of the hormone changes. And so if you have excessive sweating because of that, adding back the hormones that your ovaries aren't making, replacing estrogen, for instance, will help with those hot flashes, those night sweats, and take away that excessive sweating. So if you're waking up in the middle of the night drenched and you have to change your pajamas and your sheets are all wet because you're sweating like crazy, that's probably a night sweat, and that's probably going to respond to hormone replacement therapy. But if all your life you've been excessive sweating, it's probably something else, and there are other medications and treatments for that.
Okay, we have a question that a lot of people ask that I think is important for us to review. Charlene is asking, how long does it typically take for hormones to take effect?
So most people feel some benefit in the first few weeks. There are some symptoms that are sort of early winners. Most people get some relief from their hot flashes. Most people get some improvement in their sleep within the first few weeks of treatment. Some of the other things, weight loss tends to take a lot longer. Muscle gains, hair changes, those things tend to take a lot longer. That can take several months before you really start noticing improvement. And then there's a lot of stuff that's in between. And the truth is, it's really variable, and it depends on the patient. So the general rule of thumb is that by about 10, 11, 12 weeks, by about 3 months or just under 3 months into treatment, we have a pretty good idea if the medicine's working, or in particular, if the dose we've chosen is working. So if by that time you're not feeling some substantial improvement, it may be time to adjust the dose. You'll still probably, in some of these areas get improved, more and more improvement. So, hair improvement, for instance, that takes a long time for most people. The weight gain, I like to say, let's say that a lot of women all of a sudden, it seems like overnight, all of a sudden they put on 20 or 30 or 40 pounds. And to reverse that, it's like reversing a moving train. You got to slow down, then stop the train, and then you can get it to go the other way. And so it can take time. And so if you get to that 3-month point and you haven't lost any weight, but you realize, hey, I stopped gaining weight, we've actually accomplished a lot. Even though, you don't get that happy feeling on the scale going down, hey, you're no longer gaining weight. That's a big change. And then you can expect that momentum to continue and into weight loss. So for most women, they're feeling some benefits in the first few weeks, but really by 3 months is kind of when we make kind of a decision on dose adjustments, but then you can continue to see improvement as you keep going.
So we have a follow-up, and I'm not sure if this is connected. April asked the question about excessive sweating, and that second question is, what about adding a probiotic? So I'm not sure if that's in relation to the sweating or just a general question.
My guess is it's a general question, because I don't really think that relates to sweating. Probiotics they're fine. I'm not a huge believer in them, but they seem to help some people. They're not harmful. Yogurt, honestly, is probably the easiest probiotic, and it tastes good. And it's, I like to eat the low-fat Greek yogurt. It's got a lot of protein, not a whole lot of calories, tastes good. That's a nice probiotic, actually. So, that's fine. It's one of those things, there's not a huge amount of data for it. It's not going to hurt you. And if you think it's helping, it's probably a reasonable thing to add.
Okay. We have another question about blood work. I think we covered this, but just in case there's anything you want to add, Dr. Green, Monica's asking, when you prescribe estrogen and progesterone cream, how do you determine the best dosage without blood work?
So I have an algorithm that I built. It took me about 1,000 patients to get this right. And what happens is, when I'm in my office, patient comes in, we talk about various stuff. I write a prescription, or nowadays, at least in California, it's actually illegal to write a prescription anymore. You actually have to do it electronically. So I type a prescription in. But the point is, I have to choose a dose. And so I have a dose, I choose a dose, tends to guess right. For the vast majority, I kind of get it right. Occasionally we need to adjust, but usually my first shot's pretty good. And so it took me a while to try to decipher what's going on in my brain. What are all the little things that my brain is using to come across a dose? And it took, like I said, about 1,000 patients to tease that out and get it down. And I built an algorithm based on that takes all these things about you, puts it through an algorithm, and spits out the dose. And I kind of built it after about 500 patients. And then I started watching it for the next 500 patients and adjusting it. It's like, oh, that's not what I would have chosen. How come? And so after that, the algorithm works really well, and it comes up with a dose that's really designed to be almost what you need. I always try to undershoot just a little bit, because my philosophy is that I'd rather give you a little bit less medicine than you need and have to, squeeze it up a little bit. It's like, okay, we got rid of most of your symptoms, but not all of them. Okay, let's up the dose a little bit and get rid of the rest of them. I'd rather do that than overshoot and cause you a bunch of side effects. So most of the time, I kind of nail it. But if I'm going to miss, I'd rather miss a little bit short and have to add some medicine down the road. So that's how the algorithm's built. That's how it came about, and it works pretty well. I tend to be very intuitive, and maybe this is kind of the wrong thing to admit, especially on a live Q&A, but in a class of 144, I had a reputation of being the best guesser in medical school. And it's just one of those things. I had a study buddy who was, I think, smarter than me, and I always did better than her on the test. And she'd get all mad afterwards, like, how'd you know that? I'm like, just look right. And I think there's something that goes on in your brain. You learn all this information and you can't necessarily pull it, but it's there working in the background. And so I, learned to sort of trust my gut, so to speak. And it tends to work out pretty well. So this algorithm kind of started that way, but it was built sort of more scientifically than that. But generally, any doctor, when they're writing your first prescription, which dose of this do I choose? Which blood pressure dose? There's stuff going on in their brain they can't even pull out in which they choose their dose. And so it took a lot of teasing to figure out what those factors were. I think I got it down pretty good. And it seems to work really well.
Okay, we have another question. This is about joint pain. Patricia says she's starting to experience joint pain, overall generally pain, but mostly in the knees. And it happened when she started menopause. And she wants to know if there's anything she can do. And she's already taking Winona. She's already on a treatment plan.
So joint pain is actually a surprisingly common symptom of the menopause transition. And we do see a lot of that. On the other hand, there's a lot of other reasons for joint pain that also tends to manifest at this age. So there's a lot of wear and tear injury. I know I did a lot of stupid things when I was young, thinking I was immortal, and I'm paying for them now that I'm 59. And it's like all the dumb things I did when I was 20 was coming back to haunt me. And so there is a lot of wear and tear stuff that sort of shows up at this stage in life. Also, arthritis, there's various types of arthritis that tends to show up in this stage of life. So there's a lot of different reasons for joint pain. Menopause is certainly one of them. And hormone replacement therapy for a lot of people can really help the joint pain. If you find it's not helping, it may be time to visit your primary care, your family doctor, your internist to see maybe you've got arthritis or some other issue that can be treated with another approach. But for a lot of women, hormone replacement therapy does a really good job of helping your joint pain.
Okay, Catherine is asking, she's 48 and she's perimenopausal and says she has many symptoms. However, she wants to know if it's too late or is she able to start treating her symptoms now?
So 48 is actually a great age. The magic number is 60. So there's pretty good data that if you start hormone replacement therapy after 60, you take on some significant risk. But women that are less than 60 that are appropriate candidates, and if you get through the onboarding, you're an appropriate candidate, for hormone replacement therapy, have a lower risk of cardiovascular disease and a lower risk of really a lot of other things. If you look at the life expectancy, those women that take hormone replacement therapy live longer and healthier lives than women that have never been on it. So 48 is a very appropriate time to start hormone replacement therapy. You're kind of right in that perimenopause transition. We can get those symptoms controlled, also give you a lot of health benefits. So yeah, that's a very appropriate time to start treatment.
Okay. Rebecca has a question about breast cancer. She says, what is the current thinking on these types of hormone treatments in relation to breast cancer?
So yeah, this is one of these big pendulum swings that's gone back and forth over my career. And right now, there's really a lot of good data for this. Hormone replacement therapy, well, let's hit it from a couple ways. Women that don't have a uterus only require estrogen. And for those women, hormone replacement therapy does not increase the risk of breast cancer. Women that are on combined treatment, estrogen and progesterone, and if you still have your uterus, you need that, have a slight increased risk of breast cancer. But again, as I said before, if you look at the big picture, that slight increased risk of breast cancer is really sort of a, what's the right word for it? It's accounted for in this life expectancy because your risk of dying from cardiovascular disease, it decreases the risk of colon cancer, uterine cancer if taken correctly. I was just looking it up today. Non-Hodgkin's lymphoma, apparently it decreases the risk of that. So there's a lot of benefits that it decreases the risk of. So the slight increased risk of breast cancer, even though nobody wants a breast cancer, it decreases the risk of so many other things that it's counterbalanced. And so you still have a higher chance of living longer. If you have a family history of breast cancer, this question often comes up. So actually, even a strong family history of breast cancer, even if it's a hormone-sensitive cancer, is not a reason not to use hormone replacement therapy. Your risk is still incredibly small. Now, if you have a genetic abnormality, a genetic reason for breast cancer, for instance, you have a BRCA gene, or you have one of these Lynch syndromes, or these other genetic syndromes that increase your risk of breast cancer, in that case, I don't think it's a good idea to provide HRT because that increased risk then gets magnified by your overall risk of breast cancer. I can tell you that ACOG and NAMS disagree with me and they think it's not unreasonable. I'm kind of a chicken when it comes to risk. I don't want to hurt you. So like my number 1, 2, 3, 4, 5 thing on the list is cause you no harm. Okay. And so I'm really conservative when it comes to risk. And so I am probably more risk averse than most as far as, who I think I feel comfortable providing HRT for. But a strong family history of breast cancer, you don't have a BRCA gene or one of these other genes, it's really not a problem to provide HRT and your risk is really small. Honestly, it doesn't mean you're not going to get a breast cancer, but if you do, it has nothing to do with the hormone replacement therapy. So that's really the current thinking.
Okay. So I was scrolling through because I know some people are asking their questions and they're adding answers lower down. So I'm just trying to make sure that we're getting everybody's, I can ask everything at once. Okay. So it looks like we have a lot of questions about different things, mostly some DHEA questions. So let me scroll back up here. The question that is next is about what supplements. Oh no, sorry, this is estrogen and dementia. What are your thoughts on testosterone? Learning about HRT, would love to hear your thoughts. Also about estrogen and dementia prevention.
So let's talk about testosterone. Women do need some testosterone, and so if you look at what the ovary makes, estrogen is the biggie, and there are estrogen receptors in almost every cell in the body. So the estrogen is super important for your well-being. And so the primary hormone that we really need to replace is estrogen. But testosterone is important as well. Even though testosterone is thought of as this, quote, male hormone, women do make testosterone and the testosterone levels do drop. So if you look at normal testosterone levels in a 30-year-old versus a 50-year-old, the 50-year-old has half the testosterone level she had at 30. It's a small drop, but it's a significant drop. It does make a difference. And so that can decrease libido. It can change the way, weight is gained. It can be partially responsible for why women tend to gain more weight as they go through the menopause transition. It can change where the weight is deposited. So it tends to push it centrally, which is not a good place to carry weight. Really from a medical point of view, but even cosmetically, people don't like that. And so testosterone replacement is important. The problem with testosterone replacement is a couple of things. The first is it's tricky. So it is the one place in hormone replacement therapy where labs actually are useful because testosterone levels are normally low in women. the so-called therapeutic window is very narrow. And what the therapeutic window is what does it take to get you where you need to be, and what does it take to make it toxic, to give you bad side effects? And that difference is pretty small. So it's kind of a hard number to hit. So it's really easy to overdo testosterone and push people into the toxic range. And then you get all these, what they call andronizing or male type side effects. So you can get acne, you can get hair on your face, you can get male pattern baldness, you get voice deepening, you get clitoromegaly, and some of these are irreversible changes and not desirable. So it's really easy to overdo the testosterone and cause problems for people. And again, the last thing we want to do is cause you a problem. So that's part of the problem with testosterone. It's tricky. The other problem is, quite honestly, it's a practical issue, and that is that with the type of telehealth we do in most states, we can't prescribe testosterone if we wanted to because it's a controlled substance. So that's a very practical reason that we don't provide testosterone. Fortunately, there's a workaround. And so DHEA is a hormone, it's a bioidentical hormone that gets broken down by your body into estrogen and testosterone. It's mostly the testosterone we're after with DHEA. DHEA is nice because if you keep the dose to 25 to 50 milligrams, you're not going to overshoot. So you're going to stay in that therapeutic window. And for the most part, we don't have to worry about the testosterone side effects. You might get some mild ones. You may get a little acne. It's very rare to get the facial hair, but to get the other side effects that we really worry about, the male pattern baldness, the voice deepening, the clitoromegaly, these irreversible problems, you don't see that with DHEA at 25 to 50 milligram dosing. Now, here's the problem with DHEA. DHEA is a performance enhancing drug, and people use this in massive doses to get big and to perform better athletically. So I go to the gym a lot. I'm a big gym guy. I am what they call a natty. So I've never used testosterone or any of this other stuff. I've got a bunch of pals in the gym that do, and they're not shy about it. And hey, whatever they want to do is great. They're huge and they like that, and that's great. One of the things that they use is DHEA in these giant 200, 400 milligram a day doses. In that dosage range, it can cause a lot of problems. And because of that, there's all this scary stuff on the internet warning you about DHEA. Because you can go on Amazon and buy 100 milligram DHEA, and it's really easy to take 2 or 3 of those and cause yourself all kinds of problems. And so DHEA is something that's easy to abuse is the wrong word, but easy to take too much of and cause side effects. But when used carefully, 25 to 50 milligrams, it's just enough to goose that testosterone level back into normal female range without knocking it into male ranges. And so it gives you those benefits, the increased energy, the increased libido, weight loss, particularly loss out of the central weight, and these things without kicking you over into the problem zone. And so we use DHEA as our testosterone at Winona, and it's worked really well for us. And we have a lot of patients that are very happy with it. The other unfortunate thing is that there are some patients that have side effects, and those patients tend to be vocal. And so if you go on, for instance, a Facebook women's group, you'll see all kinds of negative stuff about DHEA, because when everything's going great, you're much less likely to make a thread on social media than when you're having problems. And so social media is skewed towards that problem stuff. So your thread is going to be more popular the more dramatic it is, plus you're much more likely to make a comment if you've had a problem. So sometimes people go on social media or the internet and they get afraid of the DHEA, but actually it works quite well. It's very safe when used correctly. And the vast majority of the patients that I have on it are very happy with the results. So that's sort of the testosterone issue. It's how we handle it and why we handle it that way at Winona.
Okay, we have a question. I don't know if we have an answer for this one, but Anna is asking if we can give them some sort of code to give their insurance company for reimbursement, that they would like a code.
So we have a lot of patients that use their HSA and FSA cards. Those are actually pretty easy. And we have some patients that have successfully gotten reimbursement from their insurance. We have receipts that are designed for insurance companies, and those are downloadable and you can use them to fill out your insurance forms and hopefully get reimbursed from insurance. We don't fill out specialty insurance forms. So just to let you know what we do and we don't do. And there's a couple of reasons for that. One is it's a huge time suck. And honestly, it's just not worth it. And it may be worth it to you, the individual, but as a company, the resources we have to spend to try and fill out all these different insurance forms is really just insane. And so it's something that we've elected not to do. The other thing, honestly, when we first started and we were a really small company and we were trying to make everybody happy, we started doing this. And what we found is that insurance companies that weren't accepting the normal stuff and were wanting special stuff would still deny it. And every time you would fill something out, they'd deny it and ask for more. And it's deny, deny, deny. So it doesn't seem to help anyway, and people weren't getting reimbursed even back in the day when we were filling out all the forms. So we're happy we have receipts that should work. They have all the information your insurance should need. But I just want to be totally straightforward about what we do and what we don't do and why that is. So we do everything we can to keep the costs down. And I think if you compare it to some of the other companies or some of the other things, for instance, if you compare it to pellet therapy, this is much, much cheaper. I have patients that come and they're just blown away because I'm not ordering $1,000 worth of labs and all this crazy stuff. And they're like, gee, I was spending $1,000 a month at my menopause clinic, and I feel better with this treatment without spending all that kind of money. So we try to do this really efficiently for you and keep the costs as affordable as possible. And we do sort of in general what we can for your insurance company, but we don't do special forms, and that's the reason. Yeah, I'm a straight shooter, so I try to tell it the way it is.
This is also really helpful. I think a lot of people appreciate that. I'm going to skip to a question because it was just in the feed and I just responded. It's a quick question.
Sure.
We have a current patient who is moving states. I believe they're in Texas. They're moving to Florida, and they want to know how they go about handling the transfer of their prescription or if they need to do anything special.
Okay, great. Actually, you know me. There's no such thing as a quick question. I like to talk. Sorry.
It's okay.
So Texas to Florida is pretty easy. So as long as we're in the state that you're moving to, it's really not a big problem. There's some technical issues that we deal with on our side, but it should be pretty seamless for you. Sometimes you may end up with a new doctor because not all the doctors have licenses in all the states. In fact, except for me, most of them don't. And so for you, actually, depending on which doctor, if you're in Texas, either have Dr. Vargas or I just lost Randy's last name, Dr. Davis. Dr. Davis actually is licensed in Florida, so if you have him, he can stay your doctor in Florida. If you have Dr. Vargas, then you'll probably end up with me in Florida. So what'll happen is you'll let patient services know. They'll deal with what has to be changed. We also have two different pharmacies. Twin Falls shifts to both, so you won't have to change your pharmacy. But if there's a pharmacy change, that's something that we deal with. But we deal with all that in the back end. You don't ever see it. So you just let patient services know. We take care of it, and it should be pretty seamless for you. The only thing that might change is your doctor, depending on who's licensed in the state you're moving to. Unfortunately, we're not in every state yet. We're in, I think Maryland was our 24th state. I could be wrong. It could be 23rd. I think we're in 24 now. But we're in 24 states. We've got a bunch of states we're about to add. So we keep adding. If you look at the population, we cover almost 70% of the US population. So there's a pretty good chance we're going to be in the state you're moving to, but not 100%. If we're not in the state you're moving to, we can't legally ship the medications there. So what we can do is we can front load you. We can give you 6 months of the medicines before you move. Cross our fingers, we'll be in that state before the 6 months ends up, because again, we are rapidly increasing our penetration. Or some people have arranged where we've mailed it to friends or families in other states and they've forwarded it to you, which is a legal way to do it. We just can't legally ship into states that we don't have permission to ship into. There's a lot of, I told you this one was going to be fast. There's a lot, you'd be amazed at the regulations involved in healthcare, and every state has their own rules. So obviously we have to stay legal and do things correctly. But that's how that works.
Okay, we have a question about does your doctor follow your progress? Maybe you want to talk about what that looks like.
Absolutely. So there's two ways that we do it. One is on a scheduled basis. When I set this up, I said, what do I do in my office? So if I wrote you a new prescription for hormone replacement therapy, I'd give you a 3-month prescription and I'd have you make an appointment for 3 months on your way out. And then we'd see each other in 3 months. I'd say, how's it going? And then we'd either continue the medicine or adjust it or do what we needed to do. And then I'd see you back every year. So that's what we do at Winona. So when you get your initial prescription, you won't even see it, but we'll schedule you an appointment for 3 months. It's actually 11 weeks, but it's designed to be the week before your 3-month refill would come up so that if we need to make adjustments, it's easy to do. At that 11-week mark, you're going to get a message saying, hey, there's a follow-up for you. And then there's another online adaptive interview where we ask you questions about how things are going. Things are great. It's really only a few questions. If there's issues, there's more probing questions. So it's not some big thing. It may only take you 30 seconds to fill out if everything's great, or it could take longer depending on what's going on. The doctor then reviews that and then either refills your prescriptions or talks to you about adjustments that can be made if things aren't hunky-dory to try to get your symptoms under control, or if you're having side effects, to fix those. Then we do that again in a year, and then we do that every year. And so that's the scheduled follow-up. However, we're available anytime. And so if there's an issue, you just send us a message in the portal and we'll respond to that message and work with you to try to, get things good for you. Sometimes it's hand-holding and saying, yeah, this takes a while, hang in there, things will be better. Or other times it's like, gee, we need to do this or that, or, these are ways that we can fix that or help with that. And so we're following you all the time. There's scheduled follow-up. The other thing that when I built this, I designed this as a continuity of care thing. I think that healthcare is best when you have the same patient seeing the same doctor and the same doctor seeing the same patient. So the doctor that accepts you as a new patient will follow you for all your messages and your follow-ups and what have you. The exceptions would be if you move to a state where that doctor is not in, you get a different doctor, or occasionally the doctor goes on vacation and we'll cover for them because we are real human beings. So that would be the time you'd see the doctor. If for some reason there's a personality issue and it's like, I don't like this jerk, then you can ask for a different doctor, and we're happy to do that. It doesn't happen very often. We have some really nice docs and really good docs. So it's pretty rare that happens. But everybody's got personality issues sometimes, and sometimes things just don't click, and we're happy to accommodate that when we can. There are a few states where we only have one doctor and we can't accommodate that, but we do our best to keep you happy and get you the healthcare that you want. But that's how it's set up.
Great. Okay, I have 2 questions. I'm going to kind of combine them. They're both about testosterone. They're from Kim and Sonia. So Kim is asking if our HRT has testosterone in it, and then on the back of that is Sonia wanting to know if we prescribe a testosterone cream. So I'll let you answer those 2 things.
Okay. So yeah, I kind of hit that pretty hard already. So we do not provide testosterone either as a cream or an injectable or any other way. For the 2 reasons I said. One is that it's really easy to mess that up and give you too much and cause you harm. The second is legally we can't do it with the type of telehealth we do because it's a controlled substance, just like we can't prescribe you a narcotic. So it's really looked at in the same way. So no, we don't prescribe testosterone. What we do prescribe is DHEA, which gets broken down into testosterone and will increase your testosterone levels to normal female levels, which is really where we want you. If you're looking for a performance enhancing thing, we can't provide that for you. Let me say one more thing about testosterone because it seems to be a big theme today. One of the popular things that's sprung up in the last several years are these hormone pellets, and mostly testosterone pellets. And I'll be honest with you, I'm not sure how they talk people into this, but basically what happens is they take this big old needle, they stick it under your skin, and they inject this pellet, usually testosterone, but it can also have some estrogen in it, that dissolves under the skin and releases hormone over 3, 4, or 5 months. And then that stuff gets used up and you go back in and you get this big old needle jammed in you again and more pellets put in. And this has become very popular. And the whole testosterone thing is strange. So the way that this is explained to patients by the doctors that do this is that, well, testosterone does eventually get broken down into estrogen in your body. And so it's a way of giving you estrogen therapy. And although that's technically true, it's kind of a backwards way of doing it. It's like, well, why not just give you estrogen since that's what you really need? I mean, what you need is a lot of estrogen and a little bit of testosterone, but they're giving you a whole lot of testosterone that eventually converts to estrogen. And so it causes a lot of side effects. It's really easy to overshoot and cause problems. And there's some risk involved in the procedure because it is an invasive procedure. So, and the problem is if you get this pellet and then couple weeks go by and you're like, gosh, I don't like this at all, you're stuck with this thing for 3 or 4 months while it dissolves away. And so there's no way to back it out. So this is cynical, but to me, the only real indication for testosterone pellets is that it makes the doctor a lot of money. And so I think that's why it's pushed so much, is that it's become a way of making a bunch of extra money in your office. And so people, have decided to do this because, yeah, it helps, but I don't think it's the best way to do it. I certainly wouldn't. I would try and talk my wife out of it. And so because of this, I think this is where all this testosterone stuff is coming from, because these these testosterone pellets have become so popular. But honestly, I think they're popular because it's a way to generate income for the doc. I don't really think it's in the best interest of the patient. I have a ton of patients that have transferred to us. They're kind of pellet refugees that have gone through pellet treatment, didn't like it, have come and used the cream or one of our other methods and been really happy with the results. So testosterone is not the end-all be-all for women. A lot of men use it, and honestly, probably too much. But men, their primary hormone is testosterone. But even then, I think it's overused. The TRT for men is kind of overused. But for women, it makes even less sense. Yes, a little bit of testosterone, which you can get from DHEA, is helpful, but a lot of testosterone is not really what women need.
Okay, Beth is letting us know she's been on compounded estrogen and progesterone cream that she uses at night for 2 weeks. She's feeling okay, but has mild morning headaches and wants to know if they will go away eventually or if she should check back in early. And she's taking the DHEA each morning and she says that's going well.
So any medicine can cause headaches for some people. It's pretty much just, if you look at any package insert, it's going to be in every package insert because people get headaches from medicine sometimes. The good thing is it's usually a temporary thing as the body adjusts. So it takes 3 to 4 weeks to really kind of get through this adjustment period whenever you start a new medicine. And once you get through that, the headaches probably should go away. If they aren't going away, it probably needs your attention. Or if the headaches are really bad and they're getting in the way of life, we need to come up with a way to help deal with that. Interestingly, it's usually the DHEA that's the culprit, but if the headaches are coming on in the morning before you take your DHEA, clearly it's the cream. If the headaches are mild and you say Tylenol, you take Tylenol or ibuprofen, they go away, I would kind of try to put up with it for another couple weeks. My guess is they'll go away. If they don't, there's some tricks we can do to help with that. But for the most part, the body's going to probably take care of this on its own.
Okay. Christina is saying that she started only 8 days ago. She's not feeling any relief. She understands it could take time, but she feels like it's made her symptoms worse. And she says before hot flashes, they pass quickly. Now it's taking 30 minutes to cool down, and she's not sure if she wants to wait 3 months to see if it gets better. Thoughts?
Yeah, I don't blame you. So it's not going to take 3 months for these side effects to go away. 3 months is when you're going to get kind of your maximum benefit, but you're going to be feeling better in a few weeks. Here's the issue, is that hot flushes really come from these rapid changes in estrogen. And so what's happening in the menopause transition is the ovary is less efficient at making hormone, but it doesn't just sort of gradually make less hormone. It sort of spits hormone out here and there, and you get these spikes in estrogen levels. And it's these spikes in levels that are thought to be the culprit that cause the hot flashes. So what happens when we start hormone replacement therapy is all of a sudden your hormone levels are going up very quickly. And that's like a spike in hormone levels, and it can cause increased hot flashes until that levels out and your body adjusts to that. So it's actually not uncommon to have worsening symptoms in the first few weeks of treatment, which is annoying. It's frustrating and annoying, I understand, because you're all excited, you're going to feel better, and now you feel worse. Why am I doing this? But if you can hang in there, not for 3 months, for a few weeks, those side effects start going away, and then the benefits really start manifesting. So one of the really frustrating things about medicine, but particularly HRT, is that the side effects tend to come on quick and the benefits kind of lag behind. The good news is the side effects also go away quickly and the benefits last a long time. So you kind of got to get through this sort of starting time. It's hard to do. It's a drag. But once you get through that, it's kind of like you're paying a little down payment. You should be feeling a lot better. So it's not going to be 3 months. I would expect in a few weeks, you're going to start feeling a whole lot better.
Okay. Marcia wants to know, are there any dangers with DHEA?
So everything on earth has dangers, but the risks of DHEA are really small in the 25 to 50 milligram dose. You give somebody 200, 400 milligrams of DHEA a day, yeah, there's a lot of risk involved there. Those side effects I already talked about, but there's other risks too, especially there can be complications with other medications. So for instance, somebody that's on a SSRI, like Zoloft or Paxil or one of these medications, if they take these giant doses of DHEA, it can cause a really dangerous thing called serotonin syndrome. That's not going to happen in the 25 to 50 milligram dose. And so we don't prescribe above 50 milligrams because that's when we really start seeing side effects. So it's very, very safe at 25 to 50 milligrams. It's very unlikely to see any really significant problems at the doses that we prescribe.
Okay. I think we covered this as well. So if we want to skip it, we can. Marcia was asking, if no blood work is needed, how do we know what's needed? Dr. Green and his algorithm at play.
So it's really your body. We listen to your body. Your body's smarter than any blood test.
Your intuitive skills, your intuitive gifts.
Right. But yeah, your body is a very sensitive assay of what's going on. More sensitive than the assays in the labs. And so we listen to your body, and that's really what's going to drive the equation.
Okay. Julie has a good question. It says she is having the worst hot
Marcia's was a good question too. It was just already answered once. Sorry. Go ahead. Julie's good question.
Julie's asking that she's telling us she cannot take HRT with estrogen due to 2 stents in her heart, and she wants to know if there's anything you can suggest.
So yeah, you're absolutely right. You are not a good candidate for hormone replacement therapy, unfortunately, and I'm sorry about that. I wish that wasn't the case, but taking away your hot flashes and giving you a heart attack isn't helping you any. So there are other things that can be used that are non-hormonal. There's a brand new drug that just came out, which name just escaped me, that works for hot flashes, so-called vasomotor symptoms, doesn't take care of the other things, but that would be something that may be safe for you. Also, some of the antidepressants, not that you're depressed, but they have a side effect of also helping some of the menopause symptoms. Those can sometimes help. So there are other medications that may be safe for you that can give you relief. It's not stuff that we do in Winona, but it's something that you can talk to your doctor about. And again, there are medications that may be safe for you that aren't hormone replacement therapy.
Okay. Sandra has a question that several others think is a good question too. That is, what are the guidelines for how long to take HRT? And are there any particular markers that indicate when to start lowering dosages or any or all of the hormones that someone is taking?
Great question. So there is no absolute time frame when you need to stop. So it's actually safe to be on hormone replacement therapy as long as it's giving you benefit. On the other hand, it's not smart to take any medication if you don't need it. So my feeling is you should take the fewest number and the lowest dose of medication you need to work. There's no point suffering. Take the medication to relieve your suffering, but there's no point taking a bunch of pills for no particular reason. I got to be honest, I'm sometimes shocked at the medication lists some of y'all are on, particularly some of these supplement lists. It's like, how do you manage to remember to take 20 things a day? And gosh, that's got to cost a lot of money. So I think people tend to take excessive amount of medication, and I don't necessarily think that's a good thing. But if the medicine's working and helping you, then you should continue it. And HRT is safe to use as long as needed. So the average woman is on HRT for about 5 years, but it's really variable. A lot of it has to depend on sort of when you start it, how long it takes your body to go through the transition, and a bunch of other variables. So my recommendation is after several years, try going off of it and see how you feel. It's a good test. It's not harmful or dangerous to stop HRT. It's just the symptoms could come back. So I always joke, don't do it just before your kid's wedding. Choose a time when you're not going to be under a lot of stress. But after a few years, try going off it, see how you feel. If you feel the same, there's no point restarting it. If symptoms start coming back, then you need to go back on it. As far as knowing when dosage needs to be adjusted, really benefits, symptoms and side effects kind of tell us that. So the ideal dose of medicine is the dose that relieves your symptoms without causing side effects. And that dose changes sometimes from time to time. So sometimes people be on a stable dose for a year or two, and then all of a sudden their symptoms are coming back and we need to increase their dose. Or the opposite, excuse me, I got the hiccups. Or the opposite, all of a sudden they're starting to get side effects. And so we know, okay, we need to back down off the dose. And so again, we listen to your body and your symptoms really drive that and let us know what's the appropriate dose. Breast tenderness is usually the sort of canary in the mine. That's usually the first sort of hint that we're overshooting. So if all of a sudden you're getting breast tenderness, you guys tenderness for a few days and it goes away, that's not an issue. But if you're getting breast tenderness that's not going away, that's typically sort of the first sign that your body's needing less hormone and it may be time to adjust the dose down. If all of a sudden your hot flashes are coming back, that's a sign that we need to increase the dose. And again, eventually you probably won't need this anymore and it's totally appropriate at some point. Usually I would say wait a few years to try going off it and see how you feel.
Monica has a question. Anna, I know, has several things that keep popping in. I'm going to put those together after this question and ask them all at one time. So Monica is asking, will HRT help with weight loss, particularly abdominal fat, likely due to elevated cortisol?
So the short answer is yes, it usually does. The long answer is everybody's different and sometimes it doesn't. But for most people that have weight gain because of the menopause transition, hormone replacement therapy works really well at helping with that, and particularly at that central weight and getting it off the midsection. Now, look, this is not going to be one of these things where you take it in a month and all of a sudden you're back to the weight you were when you were 18. Well, unless you're only a couple pounds away from that. But for most people, that's not the way it works. It's a really slow, gradual process. And it does work, but it doesn't work overnight. And it doesn't work by itself. So you can't sort of, eat 3 bags of chips and go to McDonald's and, and have ice cream on the way home and expect to lose weight because you're taking HRT. You still have to do the hard work of diet and exercise. But the truth is, diet and exercise doesn't work like when you're 40 and 50 like it used to when you were a teenager and you were 20. And so HRT helps it so that things go back, honestly, not to the way it was when you were 16, but it rolls that clock backwards so that things that are no longer effective are becoming effective again. And so it really can help a lot. Now, there's this new class of drug out there, the GLP-1s, the Ozempic and the Wegovy and the Mounjaro. Those things are dynamite for weight loss. And so if you're 100, 150 pounds overweight, that's where I would go. Maybe HRT as well to help with your other symptoms. But if you've got really significant weight to lose, honestly, there's some really incredible medications out there that work really well that you should look into. HRT can be a good adjuvant to that as well. And, for those of you who all of a sudden, out of nowhere, when you hit this sort of menopause transition, you gain 25 pounds and you want to get that off, HRTs should be very helpful for that. So that's kind of the thing about weight loss.
Okay. Anna has several questions. I'm going to put them all here. Go through them one by one. All right. First is, do we have HRT for men? is there a meal plan that we use at Winona, or do we have resources? And are the hormones that we prescribe addictive? Ready,
Okay.
set, go.
So let's hit the easy one first. They are not addictive. You can quit anytime. No, I'm kidding about that. But they aren't addictive in any way. They're not mentally addictive. They're not physically addictive. If you decide to stop, you can just stop them. It's not going to cause a problem with your body. There's two different kinds of addiction. There's addiction we usually think of when we hear about addiction, alcohol, drugs, gambling, that kind of stuff. But there are other medications. For instance, beta blockers have this addiction thing. If you're on a beta blocker for your blood pressure and you stop it right away, your blood pressure rebounds really quickly and you can get into really dangerous hypertension. It doesn't just sort of go back to where it was, it can shoot up crazy. And so for certain medications like beta blockers, you can't just stop them right away. It's really dangerous to do that. You've got to wean yourself off of them. Hormone replacement therapy isn't that way. You can stop it all at once and it's not going to cause you any problems. Your hot flashes and your night sweats and your brain fog may come back, but not rebound and come back worse. So it's not addictive in the way we usually think about addiction, in that, oh my God, you've got to have more and more. But it's also not addictive in the way that you can't stop it if you need to or you want to without having a problem. So it's really not addictive in any way. Sorry, give me the other two.
Do we have a meal plan, and do we have HRT for men?
HRT for men. So we do not provide HRT for men at Winona. It goes back to the do what you do and do it really well. Most of us are OB-GYNs and really have no business taking care of men. It's totally different physiology. Male HRT is generally testosterone. So they actually call it TRT, testosterone replacement therapy. And there's a place for that. So I did say earlier that a lot of men, more men than should be, are taking testosterone, but there are a lot of men that need testosterone replacement therapy as they advance, through their transition. And that is, it's a whole different thing. And it's honestly something that I don't have skills to do. And again, as I've explained more than once, we really can't provide testosterone on our platform. So we don't do male HRT. It does exist. It's called TRT. And there are good companies that do that. If your husband or your significant other or your brother or whatever is looking for that, if that's where that question's coming from. But unfortunately, it's not something that we can do at Winona. And then a meal plan, we don't really have a specific meal plan for you. Basically, high protein, low carbohydrate diet is generally sort of a good diet for most people. But we don't have there isn't a specific menopause diet. It really, stay active, exercise, eat, try to make healthy choices when you eat. Don't go crazy, counting every last calorie or going, nuts with this. It's okay to eat like a human being. But, try and stay away from the buffets and, the ice cream parlors and that kind of thing. It's pretty common sense, really. Eat healthy, eat less. And the hormone replacement therapy should help get the weight off if you decrease your caloric intake and stay active.
Okay. Michelle says she's been going through menopause for over 4 years. She goes 3 to 4 hot flashes an hour. Yikes. That lasts for 5 to 6 minutes long, all day, every day, and all night. She wants to know if you think it will take longer for HRT to work for her. And she's been on it for 4 weeks and it's not working yet. And she's taking the DHEA and the cream.
So the answer is, apparently it's going to take longer for you because we have that information. If I had to put a bet down and you didn't give me that last sentence, like let's say that you hadn't started yet, I would say, here's somebody who's going to be really happy in a few weeks. Usually hot flashes is an early win, but for some people they're pretty stubborn and they can take a while. So I still hold out hope that this is going to help you. It is possible that you're going to need a higher dose of estrogen, and that may be why your hot flashes are like so much on the aggressive side, in that you may really need a lot, more estrogen in your cream. And so, it's pretty easy to increase the dose of the estrogen. in the cream, and your doctor can help you with that if you message them. We usually try to encourage people to hang out for that 10, 11 weeks because that's really when we see the maximum benefit. If you change the dose too early, you end up on a higher dose than you need because you haven't really given it time to work. But at a month and you haven't felt anything yet, maybe goosing your dose a little bit might make sense for you.
Okay. Amy has a question about spotting. She says she started HRT 3 days ago and she's spotting. Is that normal?
Yes. So the answer is yes and no. When you first start hormones, that hormones can trigger some bleeding, and it's not that uncommon to have spotting or even to have a period in that first month or so that you start hormone replacement therapy. So it's scary for people and it's annoying, particularly somebody who maybe they haven't had a period in 3 years and they start HRT and 2 weeks later they're having their first period. That's scary. The truth is that's pretty normal. Most people don't get that, but people do. And that's not really a danger sign. The danger sign is you've been on a stable dose for 5 months and all of a sudden now you're having bleeding. That's something that we need to pay attention to because sometimes the hormones can uncover an underlying problem that we didn't know was there and it needs attention. But that first few cycles, sometimes it really throws the periods off and it'll take a little while to equilibrate and kind of get you back to whatever your normal is. So first few days, I really, it's annoying. So I'm sorry, but it's nothing to worry about and it's temporary.
Okay, Shannon is wanting to know, what does it feel like to have too high of a dose? Low dose, is it less effective in your symptom relief? But if you have a high dose, what would that do?
So as I said before, usually the first sign of a high dose is breast tenderness. That's kind of the canary in the mine, so to speak. Not everybody gets that, but that's usually kind of an early warning sign that the dose is too high. Symptoms that weren't there, side effects that weren't there that all of a sudden sort of show up. So let's say you've been on a stable dose for 3 or 4 months, and then all of a sudden you're getting nauseous or having other symptoms, or you start bleeding. That could be a sign that you need a dose adjustment. But honestly, the breast tenderness is usually the giveaway for me. And that's usually, it's early and persistent, and it usually happens before anything else. So that's the most common sign that the dose needs to be brought down a bit. Okay. The other one would be sort of overly emotional. You feel like you're pregnant where you're crying at these stupid commercials, and that kind of thing. Sorry, that almost got through your nose. But and that can happen at the beginning. Again, these changes in hormones. But if everything's going well and all of a sudden you're sometime into this and that starts happening, that could be a sign that we may be a little bit high on the estrogen.
Sorry, I skipped down to the bottom and there's a good question here, so I want to just ask it while it's fresh in my face.
You're all over the place tonight.
I am. I'm seeing so many questions in the queue, and I'm like checking to see if there's some repeats so we can cover our bases. Danina is asking, what are the effects of HRT on polycystic ovaries?
Good question. So PCOS tends to be a bigger problem the younger you are, and it tends to get better with age. So menopause actually cures PCOS when you go through it because it really has to do with an imbalance in the way your ovaries making hormones. And so when your ovaries stop making hormones, the PCOS basically goes away. So that PCOS on its own tends to get better through the menopause transition, which is kind of one of the few things that tends to get better. Part of the issue with PCOS is really an imbalance in hormones, particularly estrogen and progesterone. And so HRT can help reestablish that balance and treat some of the symptoms of PCOS. So it tends to be something that can help with some of the PCOS symptoms. Depending on, everyone manifests PCOS differently. It's kind of an interesting syndrome, which is why they call it a syndrome. And so you see, a lot of women with PCOS struggle with their weight, but you have skinny people with PCOS. And some people with PCOS have a real hard problem with facial hair. Other people don't have that at all. There's all kinds of different ways that it manifests. So if you have the type of PCOS that gives you these sort of heavy androgenic symptoms, these male type pattern symptoms, the DHEA may not be a great thing to be on. So that would be one way that I would, if you tell me about PCOS and you have all these symptoms, maybe we shouldn't start you on DHEA because you don't need that extra testosterone. Because one of the things for some women that they have with PCOS is really an increased testosterone level. And so the last thing you want to do is increase that more. So those are some of the subtleties, but in general, it tends to help PCOS.
Okay. All right. Okay, Tammy. Wait, let's see. We answered. Michelle put her question twice, so I think she popped it in the chat a second time because we were taking a minute to get to it. Okay, Lindsay is asking. She says she just joined. She asking us, why wouldn't you want to know what someone's progesterone and estrogen levels were prior to starting? As a nurse myself, these labs can be valuable if samples are collected correctly. And what if you start without knowing those levels and someone is getting too much of either?
So the first answer is there is no good way to measure these levels because the levels are all over the place. So you can measure them now, and I can measure them again in 3 hours, and I'm going to get completely different numbers. And that's true whether you're doing blood tests, Dutch testing, saliva tests, hair tests, urine tests, doesn't matter. These levels really are variable. There isn't really a good way to measure them. So that's really the bottom line. But the other thing is they're not useful because I don't need the levels to know what your levels are. Your body tells me what your levels are. Your symptoms tell me much better than a lab test where you are in this hormone transition. I've had people that have both their ovaries removed and they, for some reason, do a test and it tells me their estrogen is way too high. It's like, well, that can't be true. Or the progesterone is way too high. It's like, well, where's it coming from? You don't have ovaries. Yes, you can make a little bit of estrogen in your fat tissue there and in your adrenals. There are places where estrogen come from. There's no way you have high levels if you've had your ovaries removed. And I've seen that. And so these levels really, they're just not helpful because they're not accurate, no matter how you test them. So that's the first thing. The second thing is it's just a waste of your time and money because not only aren't they accurate, but they're not necessary. I can do a much better job deciding on what you need and how much you need by listening to you and listening to your body than I can by pulling labs out of Quest. So I know this isn't what you're hearing. It's really different than other things that we treat. We're treating your thyroid. We absolutely need levels for that. It's a totally different thing that we're treating, and it behaves very differently. And thyroid, for instance, TSH is very accurate, and it tells you a whole lot about what's going on. And you really need that to dose thyroid replacement. Honestly, if you're doing heavy-duty testosterone replacement, let's say you're a competitive bodybuilder and you're getting ready, you're prepping for a meet, and we're pushing your testosterone to get your body in the condition we want. Yeah, we're going to need to draw labs to do that. So there are places for this, but for doing hormone replacement therapy, it's really it's a waste of time. It's not accurate. I personally think it's inappropriate to make clinical decisions based on it because the numbers aren't accurate, and to try to make decisions on numbers that aren't accurate really puts you at risk. And this really hurts women. It happens a lot. You get, especially because people really underestimate how young some women are when they start going through the menopause transition. When you realize that 15% of women complete menopause by 45, and these symptoms start 7 to 10 years before that, it's not uncommon to see women in their late 30s with symptoms of the menopause transition. But these same women who are really suffering, they go to see their doctor draws labs because they don't really understand. And their labs look relatively normal. And they tell them, oh, this is, you don't need hormones, this is not that, don't worry about it. And they get denied the treatment that they need because somebody's making a bad decision based on numbers that aren't really meaningful. It's not the same as checking, you're a nurse. It's not the same as checking your potassium when you're doing potassium replacement. It's not the same as somebody who's septic and you're checking their white blood cell count and following that. It's not the kind of thing that we do in other aspects of medicine where the lab values can be really beneficial. It's not the same as checking, your cholesterol levels and your LDL and your HDL and following that to see how the statins are working. This is really a very different thing. And it really requires a different way of thinking and a different way of diagnosing and managing if you really want to do it well and do it right. And lab tests are not the right way to do it well or do it right.
Okay. Question from Tamara is asking, if she has a glass or two of wine every night, will it affect the results or cause any negative side effects?
Probably make you happier. Sorry.
I like your honesty over here at Winona.
So yeah, there's nothing wrong with having a glass of wine now and then. It's really interesting though. 2 glasses of wine every night, every day, actually can cause health problems. It has nothing to do with the hormones. It's fine to take your hormone replacement therapy if you drink too much wine. To an extent. But look, I like to have a drink. Along with I drink cheap wine. Gin and tonic is kind of what I drink when I go out. So I don't have a problem, but I like to drink now and then too. But really, it's not a problem to have a modest amount of alcohol and hormone replacement therapy. But really, 2 glasses of wine every night can actually lead to health problems. So just saying. But there's nothing wrong with enjoying a glass of wine or 2 now and then, and it's not a problem with the medication.
Okay. Wendy would like to know, and this sort of goes with Lorraine's question, do we ever need to go off of HRT? And the next follow-up to that is, how stringent is the don't start HRT after 60 guide? If someone just turned 59, will they have to stop HRT next year?
So let's start with that, because that's the question is there's 2 parts to that, and one is right and one is wrong. So you don't need to stop HRT when you turn 60. You shouldn't start someone on HRT for the first time when they turn 60. And that has to do with cardiovascular effects. So as long as you've been on HRT before you turn 60, you can continue it as long as it's helpful, even if you're over 60. The big thing is that we don't start HRT on women over 60 because it increases the risk of cardiovascular problems, as opposed to women under 60, where it actually decreases those risks. So 60 is sort of the break number, where it's just a statistical number where it breaks out. Honestly, look, there's no difference between someone who's 59 and 364 days and 60 and 1 day. I mean, really. But you have to draw a line in the sand somewhere, and if you don't sort of hold that line, then you start moving that line, and eventually you cause problems for people. And so that's where the statistics, and so the medical community is sort of drawing the line in the sand is at 60. But it's safe to continue HRT after 60 as long as you've been on it before that. And then the first part of that question was how long?
Is there a point at which you have to stop HRT?
There's no point that you have to stop, but there may be a time when it's no longer useful. And we sort of talked about that. And so it's appropriate after a few years to try going off of it and seeing how you feel. Again, we're going to judge this by symptoms. And if you're not feeling any better with it than without it, then there's no point taking the medicine. If you find that you go off it and a week or a month or 2 months or sometimes 3 months later, all of a sudden you're feeling miserable again, you probably ought to go back on it. So as long as you're just making your life better, then it's reasonable to stay on it.
Excuse me. Okay, Martha is asking, she's telling us first that her OBGYN confirmed with lab she's in perimenopause, so why would she decline to prescribe HRT? Get your crystal ball.
Okay, so I don't know why your doctor would, because that's an individual decision, but I can tell you the big picture of why this problem exists. So I finished my OBGYN residency in 99. I got my MD in 93. So I've been doing this a long time, long enough to see some really crazy changes in HRT. Before 2002, we were giving HRT to everybody. Like, we thought it was a vitamin, 90-year-old, oh, you need HRT. That was the data at the time, is that it was good for people and everybody should be on it. When the Women's Health Initiative study came out, it made these big headlines that, oh my God, we're killing people with HRT, and everybody panicked and stopped prescribing HRT. I remember that day, the phone was ringing off the hook with these women just panicked that oh my God, I'm gonna die because you gave me HRT. When you really look at the study, that's really not what it said. What it said was that, hey, this is a medicine, not a vitamin, and you got to be careful about how you prescribe it. And if you prescribe it inappropriately, you're going to cause problems. And this is, out of that, a whole bunch of other studies have come out over time, and we've kind of refined this down. And that's where that age over 60 thing comes from, and these other things. And now we know what the criteria are to safely prescribe HRT. So if you know what you're doing and you do it correctly, HRT can be not only very beneficial, but it can be very helpful and increase longevity, decrease certain medical conditions, and really help women. The problem is there was a sort of big gap in knowledge from that Women's Health Initiative study came out in 2002, and really 10, 15 years later before the pendulum ever started to swing back. And so a lot of doctors that were in training at that time never got any training on how to use HRT. Because basically it was like, look, you're never going to prescribe this stuff. There's no point wasting your time learning about it. You got enough stuff to learn. This is not a history class. And so there's a whole generation of doctors that really never got good training on hormone replacement therapy. And so they come out of residency and, they don't know how to use it. They were told they were never going to prescribe it. And so they're not comfortable prescribing it. And doctors aren't going to prescribe something they're not comfortable with. There are whole health systems that won't prescribe HRT. So Kaiser, if you're California, you know that name. Kaiser is the biggest health provider in California. And they pretty much as a rule don't do HRT. It's kind of awful if you ask me. And the HRT they do prescribe, all they use is really this old HRT, this old forms of medicines that are like the worst ones. They have the most side effects, they have the most risks. Like, why would you use that? It's the only thing they have on the formulary, and most of their doctors, as a rule, just won't prescribe it. I have a lot of Kaiser patients that come to Winona because their doctors say, look, I don't do HRT. And so they come to us and we take care of them. I've had a few, in all fairness, it's kind of interesting, and I'm happy about this. I've had some patients that come to me from Kaiser with that story. I provide HRT, and then they send me a message 3 or 4 months later. Thank you so much for all you did. My doctor has seen how much better I am, and they're willing to take over my HRT, and they can do it for free because it's Kaiser. And I'm like, good, I've educated one more doctor. I'm happy about that. But unfortunately, there's this education issue and this fear, this inappropriate fear of HRT that a lot of doctors have. And so some people, even though they recognize that it's probably helpful, they don't know how to do it and they're afraid to do it and they don't prescribe it. I don't know if that's what's happening with your doctor, but I can tell you that is a general problem that we see in the in the healthcare community with HRT. Honestly, and I hate to say this, but it's one of the reasons we're successful, because we're a haven for women that aren't able to get HRT when they should be able to get it. And so, I'm not happy that it's good for us, but it's just a reality that's one of the benefits that we bring to the table, is that we provide a medication that's safe and effective, that for this historical reason, a lot of doctors aren't willing to prescribe. And so we're an outlet for people to get the medicines they need when they otherwise couldn't. So it's been good for our business. It's kind of bad for society, but I'm glad we can help. And so it's good for our business, but more importantly, it's good for our patients because they're able to get medicine that they wouldn't otherwise be able to get. Sorry, I kind of went down a bit of a rabbit trail on that. I tend to be a little passionate about HRT, so I apologize if I tend to go off.
Anna would like to know what happens to your cycle. Like if you're still receiving your period and you start HRT, how does that affect things?
So as I mentioned earlier, the first couple of months, it's sometimes, not always, but it sometimes throws the cycle off. So you may have some irregular periods or you may get some bleeding in between, and it can throw the cycle off. But once the body adjusts and we get past that first couple of months, usually cycles will return to whatever is normal for you. Every woman is different. It's amazing how different cycles are for different women. But whatever your sort of baseline normal is, that's generally what you return to once your body adjusts to HRT. So for most people, it might get a little bit better, but it's really not the best thing if your cycles are a problem. That's not really kind of what it's designed to do, but it shouldn't make them worse either. Once you get past the first couple of months. It's interesting. It's so funny. I have patients that are like, well, I'm still getting periods, so I'm not a candidate for HRT. It's like, no, you're a great candidate for HRT. And then I get other patients, well, I'm not getting periods anymore, so I'm not a candidate for HRT. No, you're still a good candidate for HRT. So really, whether you're still having periods or not is sort of irrelevant. if you're having symptoms, we can take care of those symptoms.
Okay, our next question is Tammy. She wants to know if there's a risk of blood clots, getting blood clots if you're on the estrogen cream.
So the short answer is yes, but the long answer is there is an increased risk, but it's a very small increased risk. You're at much higher risk, for instance, from birth control pills than you are from HRT. Yes, there is a small increased risk. That increase is very small, and it's pretty unusual, thankfully. Now, if you have a history of getting DVTs or blood clots or PEs, blood clots to your lung, or you have one of these genetic things that puts you at increased risk of having blood clots, you really shouldn't be on HRT, because even though it's a teeny increased risk, it magnifies the increased risk you already have. But for people that have the normal baseline risk, that increase risk is very, very small. And so you're still very unlikely to get a blood clot. The way I like to think about it, look, if I told you that you're twice as likely to win the lottery tomorrow, you're still not going to win the lottery tomorrow, right? Because doubling your chance of something that's incredibly rare is still making it incredibly rare. So when you look at these statistics, it can be misleading. So even though the odds go up of something that's very rare, it's still very rare. And so yes, the right answer is yes, it does increase risk of blood clots, but your actual risk of blood clots is still incredibly unlikely to happen. And there are other things that people take without even thinking, like birth control pills, for instance, that have a much higher risk of causing blood clots in HRT.
Okay, Charlene has a question about taking DHEA pill and cream at the same time before bed. Do you advise it? Not advise it?
Sorry, I misunderstood that for a minute. So for most people, it doesn't really matter when you take the DHEA. It seems to work just fine no matter when you take it. And so my advice is when you start this, take it whatever's easiest to remember. And so if it's easiest to do it with your cream, take them at the same time. That's what I would do. That's what my wife does. It's just easier to remember that way. It's hard to remember to do something twice than to do it once. So that's how I would start. Every now and then you have people that are more sensitive to different medicines, and sometimes in opposite directions. So I have some patients, the DHEA seems to keep them awake. So I tell them, okay, take it in the morning, take advantage of that. It'll be like a little caffeine boost. Other people, the DHEA tends to make them sleepy. Okay, take advantage of that, take it at night. So for most people, it doesn't do either one, but for a small minority of patients, it'll do one or the other. So again, listen to your body, see how it affects you, and then if you need to, change when you're taking it to take advantage of what it's doing to your body. So listening to your body is really important for most of this stuff. Your body kind of drives how to do it.
Okay, next question. Gabby wants to know, are there risks with taking HRT if you have hypo or hyperthyroidism?
So the HRT should not change your thyroid. It's not going to fix it either. So if you have hypothyroidism, you need to take a replacement. If you have hyperthyroidism, you need to take the medication that helps calm your thyroid down. Really important not to stop those medications. They're very important for you, but they're really separate from HRT. So HRT isn't going to make your thyroid better. It's not going to make it worse. Now, the teeny little caveat, if you're on thyroid replacement, you may already know this, but thyroid replacement is a fickle drug. And that's why your doctor is checking labs probably at least every 6 months to see if your thyroid replacement needs to be adjusted. So it tends to kind of go out of whack on its own, and every little thing can change it. So it's not uncommon to start HRT and maybe it throws your thyroid off a little bit, not because it's affecting your thyroid, but because the thyroid replacement drug is fickle that way. There's a biochemical reason for it, which I won't go into. It has to do with sex hormone binding globulin. Anyway, we won't go into it. But so in theory, it can affect replacement that way, but not in a major way, and something that your doctor's already watching for. And that's why they're checking thyroid hormones every so often, because again, it's kind of a fickle drug and it tends to need to be calibrated. Looking at the time, my wife and I are going out tonight. I just want to make sure we're okay. I don't want to miss our reservations.
Yeah, so I have dinner as well, so we'll try to get through these last few questions. Okay, Okay, I think we covered how long a menopausal woman should be on HRT, at what age we should stop, 60. Let's see. Gina wants
Wait a
to know.
minute, back up. You don't need to stop HRT at 60. You weren't paying attention.
Oh, well, it's if you can't start it after 60.
You can start it after 60, but you can keep taking
Sorry.
it after 60.
I'm
That's
failing
all
my
right.
quiz, Dr. Green. What's happening? I'm not supposed to fail. I'm not supposed to fail these questions.
You've got a lot going on there with all these questions.
I do. Okay, so the question, Gina wanted to know if or when the bloated sensation will taper off with DHEA and cream treatment, and that she's been on things for 2 weeks.
Bloating is a side effect that some people get at the beginning. It's pretty obnoxious, but it does go away. So for most people, it goes away within a few weeks. Every now and then you have these stubborn bodies, and it can take longer, but it almost always goes away on its own. There's usually an underlying reason for the bloating that you can kind of treat while you're waiting for your body to fix it, depending on what's causing it. So if you're finding that you've got a lot of gas, you can use simethicone. Gas-X is the brand name. It's an over-the-counter medication, very safe, and that can help. If you're finding that you're having water retention and that's why you're bloating, you can use an over-the-counter diuretic. And so there are several of these over-the-counter. They're very safe to use as well, and that can help. Some people get bloating because they get constipated. In that case, treat the constipation. So drink more water, eat more fiber. You can use Colace. If it's really getting bad, you can use Miralax. All those things will help the constipation. And if that's what's causing the bloating, help the bloating. So try to think about it. Is there an underlying thing? Like, is it one of these or the other? And you may be able to make it go away more quickly, but ultimately it should go away on its own.
Okay. Skipping over here to Crystal's question. She's currently a patient with Winona and is using the bi-estrogen cream, the DHEA pill, and she wants to know, do you have the patch available, and can she switch it if possible to the patch? And also, do we have progesterone as well, because she'll need to take that?
So the answer is yes, yes, and yes. We do have a patch, and if you prefer to use the patch, you can switch to the patch. The cream, if you need progesterone, the cream has both estrogen and progesterone in it, so it's kind of convenient. It's an all-in-one thing. The patch is estrogen only, so you would also need to take an oral estrogen pill. So you still need to take a daily pill. Unfortunately, the patch is a lot more expensive than the cream, and especially when you consider that you also have to take the progesterone. So it's like at least twice as much money. I personally don't think there's a big advantage to the patch. Some people like them, and that's great. It works fine. To me, I think it'd be annoying to have to wear a patch all day, every day, but some people like it, and that's fine. Personally, I don't think it's worth the extra money, but if it is to you, we're happy to provide that. So we do have a patch, we have a progesterone pill, we also have estrogen pills if you'd rather go that route. They all work. There's some subtle differences, but for most people, any one of them is acceptable and fine, and it kind of comes down to personal preference. So that's something that you can talk to your Winona doctor about.
Okay, Lena is telling us she had a hysterectomy and kept one ovary. What would be good for her from Winona? She says she's found that her anxiety has increased since her surgery 6 months ago, and she's 41.
So if you're having other symptoms of the menopause transition, estrogen is going to be your friend, and probably some DHEA. So once you've had a hysterectomy, you really don't need progesterone. Progesterone is primarily used to protect the lining, the inside lining of the uterus. Since your uterus is in a pathology lab somewhere, we don't need to protect it anymore. So you really don't need the progesterone. So if you are having some symptoms, and these symptoms tend to come on earlier in women that have had hysterectomies, especially if you had an ovary out. So I wouldn't be surprised if you are. Estrogen and maybe DHEA, depending on your whole symptom milieu, is probably going to be helpful for you.
Okay, I think we have 2 more questions. Michelle says, if you say the cream and DHEA can give you your sex drive back, what would be the reason someone would need to purchase Blossom?
So Blossom is not for libido. Blossom doesn't work on your sex drive. Blossom makes sex better. It's really a different thing. Just the way it is. So basically, Blossom is not gonna directly increase your desire for sex. I mean, if sex is better, it might increase your desire secondarily, but it's not going to increase your libido. What Blossom does, it's basically the active ingredient in Viagra, sildenafil, in a cream form that's basically rubbed around the clitoris. You wait 30 minutes, and that gets absorbed, and it increases the blood flow to these really sensitive parts. And by increasing the blood flow, it increases sensitivity, it makes orgasm easier, and for some women stronger, and it generally increases the pleasure of sex. And so that's what Blossom is used for. But it's not something that primarily increases libido. Whereas the cream and the DHEA can increase libido, it also can, the estrogen in particular can make the vaginal tissues more healthy. So over time, it also can increase blood flow, increase lubrication, make sex more comfortable, and so also increase the pleasure, but really in a very different way than the Blossom cream does. So the Blossom cream is kind of used as needed, kind of an extra little benefit, but it's not sort of a long-term thing that changes your libido, if that makes sense. I mean, it can secondarily, but it's not really the primary use of it. So they're really different things.
Okay. All right. I think our last question is, does estrogen elevate CRP levels? That's from Christine.
Ooh, that's a tough question. CRP levels. Now I got to remember what that is.
I have this done all the time. Is the CRP like a create reactive protein? It's a
C-reactive protein.
Yeah.
Not sure, and I'm not really sure that it matters, honestly. So, I mean, C-reactive protein is sometimes used as a marker for different things, and a lot of different things can elevate it. It's kind of a non-specific marker, and honestly, more of an internal medicine thing rather than a gynecology thing. So it's not sort of in my major wheelhouse. So I was about to Google it, but
I just know that they run that blood test for me all the time, and I have an auto.
I don't know the answer to that. I don't know if it throws that test off or it changes that test. I know that test tends to be thrown off by a lot of different things, so it is possible, but I don't honestly know the answer to that, so I'm not going to make it up. But you can ask whoever's checking your CRP, they should know the answer to that.
Okay, I think that's everything. Oh wait, sorry, I missed one. Monica is asking, she's tried oral estrogen and progesterone before. It caused slight weight gain. Does this happen with bioidentical cream as well?
So it shouldn't cause weight gain, but honestly, well, it depends on the progesterone you were taking. The synthetic progesterones, particularly Provera, which is probably the most common one, is sort of known to stimulate appetite. The extreme of that is Depo-Provera, which is a birth control that's made out of this progesterone. And these poor women come in, for their second shot and they're 50 pounds up. You're like, oh gosh. And so that's sort of a classic thing of Provera, which is a synthetic progesterone. And Provera is the progesterone that's most commonly used in HRT. So Prem-Pro, the Pro is Provera. The Women's Health Initiative study was done using Premarin and Provera. And that progesterone definitely can cause weight gain by stimulating appetite. Micronized progesterone, which is the bioidentical progesterone, really doesn't do that. It doesn't stimulate appetite like Provera does. So really, HRT, big picture, shouldn't cause weight gain, although, like I said, some of the synthetic progestins can do that. Bioidentical HRT certainly should not. Now, it can cause water retention at the beginning. So some women in the first few weeks get a bunch of water retention, and it's terrible because all of a sudden they look down, their scale is 5 or 10 pounds up, which is a terrible feeling. Believe me, I wouldn't want that either. But it's temporary, it's not real weight, it's water weight. And it goes away on its own as those shifts take place. But that is sometimes an initial side effect. But in general, HRT should not cause weight gain. It really should make it easier to lose weight.
Okay, I lied, Dr. Green. I'm going to combine these two questions and then we'll sign off. Because I know you have to go and so do I. Anna and Lena, the combo question is, are fibroids affected with HRT, and is the pill or cream better, one versus the other? Do you have an opinion?
So fibroids should not be affected by HRT except for really extreme cases. Fibroids are interesting. If you took 100 women off the street that had absolutely no symptoms, and you did ultrasounds on them, at least 25 of those 100 women are going to have fibroids. Never cause them a problem, they're just there. But for some women, fibroids can cause huge problems. And honestly, it's the most common reason that we have to do hysterectomies. So I'm not saying fibroids don't cause problems, because they absolutely do. But the majority of fibroids actually don't. And so for most women with fibroids, HRT is not going to cause a problem for that. And even with women with bad fibroids, the amount of estrogen in HRT, and particularly if it's, and it will be if you still have a uterus, combined with progesterone, really shouldn't activate those fibroids. So for most people with fibroids, HRT is perfectly safe. It's pretty rare. I've had maybe 1 or 2 patients out of thousands. There's a handful of women that I've seen where their fibroids are just so sensitive that HRT is enough to cause problems, but it's pretty unusual. It's really very rare. I wouldn't say it can't happen, but it's pretty darn uncommon. And then the pill or cream question. There are some theoretical reasons why the cream is safer and has less side effects. But honestly, for most patients, the pill and the cream both work well. They're both safe. It really kind of comes down to personal preference and cost, and kind of how you want to do it. So the cream is a nice approach because you get the estrogen and progesterone in the same cream. Bypasses what's called the first pass metabolism, so it does have less effect on the liver, which in turn gives you less risk of blood clots and some other, less lipid effects and these kind of things. For most people, though, those differences are small enough that it doesn't make any real difference in true outcome. But they're there on paper, and for some women that have some specific issues, the cream is going to be safer. But honestly, for most people, the pill and the cream both work well. And it kind of comes down to personal preference. That's the way I look at it.
Okay, everybody, I think we answered everyone's questions. If we didn't, please go to our YouTube, check out our previous videos. Some of these questions get asked regularly. So if we didn't get to your question tonight for some reason, or you want to rewatch some of our older episodes, you can go to YouTube and listen to Dr. Green and sometimes Dr. Cat answer these questions. You can join us every month. We're having these Q&As, so we're here for you. Thank you, Dr. Green. Hopefully you can go enjoy your dinner. And yes, if you have questions, join us also in the women's group if you want to be a part of a community full of women. There's about 8,000 women there, so feel free to join. You do have to request to join. Just hop over to Facebook and add us, or we'll add you. And we'll see you guys next time.
Great. And don't be shy to ask your Winona doctor these questions. We're happy to answer them online for you as well.
Yeah. Awesome. Okay, everyone. See you soon.
Thanks, y'all.
Thank you. Bye, everybody.